It's really hard for me to breathe.
What respiratory challenges are associated with obesity in children, and how might this affect your management plan for this patient?
Should I answer? Or does this doctor know everything?
In obese children, decreased chest wall compliance and fatty infiltration of upper airway structures lead to restrictive lung disease and extrathoracic airway obstruction. This can result in difficulties with both basic and advanced airway support. Post-induction lung volumes often fall below closing capacity, increasing the risk of atelectasis and hypoxemia. This means that, for this patient, you should anticipate difficulty with bag mask ventilation, possibly requiring two-handed BMV, and early use of an oropharyngeal airway to maintain a patent airway.
Considering the patient's weight 50 kg and ideal body weight 35 kg, how should you dose medications such as succinylcholine and rocuronium during rapid sequence intubation?
Medication dosing in obese children should be carefully calculated. While most medications, including those used in RSI, like succinylcholine and rocuronium, should be dosed based on actual body weight, due to the larger volume of adipose tissue increasing the volume of distribution.
Is there a problem with my weight again, doctor?
What position should the patient be in for induction and why?
It's more convenient for me to sit than to lie down.
Induction should be performed with the patient in a semi-recumbent position, head of bed elevated. This positioning helps mitigate abdominal pressure on the diaphragm, improves lung expansion, and can help establish a proper sniffing position for intubation, making it easier to visualize the airway.
What challenges might you face during bag mask ventilation in this patient, and what strategies could you use to optimize ventilation?
BMV may be challenging due to airway obstruction from both obesity and obstructive sleep apnea. To optimize ventilation, you can use a two-handed technique to ensure a good mask seal, and consider the early use of an oropharyngeal airway. Positive pressure with BMV may also be necessary to overcome upper airway resistance.
After an initial failed intubation attempt, what alternative strategies can you use to manage the airway?
Does that happen, too?
If the initial intubation attempt fails, it's important to be prepared for a difficult airway. Alternative airway devices, such as laryngeal mask airways, can be used to optimize rescue ventilation before attempting another intubation. It's also important to have advanced airway tools available, including large laryngoscope blades and short laryngoscope handles, which may be needed for better visualization in obese children.
What are some key considerations when selecting the size of airway equipment for this patient?
While airway equipment size, such as endotracheal tubes, should be based on ideal body weight, the use of larger laryngoscope blades and short handles may be necessary to adequately visualize the obese child's larynx. This can help improve your view and increase the likelihood of successful intubation. A thoughtful approach, considering factors like medication dosing, patient positioning, and the use of alternative airway devices, can improve outcomes in this difficult situation.